Assalamu alaikum and a very good afternoon to all of you. Thank you, Professor Seema and Dr. Shazia, to give me first lecture on this forum. To develop any specialty or super specialty, the foundation should be very strong. So that is why the pelvic floor anatomy, rectum and urinary bladder is the foundation to develop urogynecology. So we are proceeding with the first lecture, that is anatomy of the genitourinary system, pelvic floor and rectum. Now after this session, the learners will be able to describe the anatomy of the genitourinary system, anal canal and the rectum. And secondly, they know how to explain the functional role of these muscles to control or to have a urinary continence and fetal continence. Third, the most important part, how, if there is any, you have to identify what are the potential spaces that can lead to pelvic floor dysfunction. Any first year PG? Can you name one pelvic floor dysfunction? Any nursing staff? Just name one pelvic floor dysfunction. Okay, so this is important that after attending this session, you are able to at least know the name of one pelvic disorder. So we all know that the pelvis is made up of 4 bones, 4 joints. Go back to the UG classes. So it is formed by 2 innominate bones, 1 sacrum, 1 coccyx, and there are 4 joints, 2 sacroiliac, 1 sacrococcygeal and pubis symphysis. And we also know what is true pelvis and false pelvis, that is divided by the pelvic inlet. So we concentrate basically on true pelvis. So when we talk about perineum, so just remember it is corresponding to the outlet, anatomical outlet, and the points are lower border. Okay, so when we go to the perineum, it is bounded anteriorly by the symphysis pubis, by the side ischial tuberosity, and posteriorly by the coccyx. So it is a rhomboid shape and divided by a line that is passing through the ischial tuberosity, and it divides the perineum into 2 triangles. Urogenital triangle is an anterior triangle and anal triangle is a posterior triangle. So what passes through the anterior triangle? As it goes with the name urogenital triangle, so it permits what? Urethral meatus in the vagina. Next is the perineal membrane. So perineal membrane, you can see it is a triangular membrane and it is bounded by the boundaries of anterior triangle. And there are 2 openings, urogenital hiatus, which permits opening of the urethral meatus in the vagina. Now coming to the superficial fascia. So superficial fascia of abdomen and the perineum. So the superficial fascia, superficial layer of the lower abdominal fascia, that is known as the camper fascia, and laterally it is connected by the fascia lata or the fascia of the thigh, and deep fascia of the abdomen is known as the scarpa fascia, and when it continues in the perineum, it is known as the Colles fascia. So when we talk about the pelvic fascia, the parietal fascia, it covers the muscle, while the visceral fascia, it covers the neurovascular system and the pelvic organs. Now there is 2 important things. What is superficial pouch or the superficial compartment, and what is deep perineal pouch or the deep perineal compartment. So whatever lies below the perineal membrane is formed by 2 layers, superficial and deep. And the space between the perineal membrane is known as the superficial compartment, while the space below the perineal membrane is known as the deep compartment. And the contents of the superficial perineal compartment is, there are 3 muscles, ischiocavernosus, bulbocavernosus and superficial transverse perineum. Now we talk about the deep perineal compartment which lies below the perineal membrane and it is having a deep perineal muscle. Now coming to the pelvic floor. Pelvic floor also known as a pelvic floor, it is formed by pelvic diaphragm and laterally there are two muscles, piriformis and the obturator internus. So pelvic diaphragm, it is a funnel shape made up of various muscles and the important thing is that whenever there is the direction of the pelvic floor muscles is anteriorly and medially, when they contract, they approximate the opening, that is the urogenital and that prevents the so contraction of the pelvic diaphragm, it closes the genital hiatus and provides a horizontal levator plate on which the pelvic viscera lies. So it is one of the supportive pillar for the pelvic viscera. So levator ani, again not going into the detail because I have to justify myself I have to justify with the time also. So not going into the detail, we know that levator ani muscle is made up of 3 components and the most important is puborectalis. So the important part puborectalis, antemedial fibers, it forms a sling around the rectum and that helps in the continence of the feces. And it also maintains the anorectal angle which is around 90 degrees at resting phase. So again puborectalis is the intermediate part of the levator ani and ischiococcygis is the posterior part. And coccygeus or the ischiococcygis is a small triangular muscle and you can see it is situated posteriorly. Now levator plate, again there is a role in prevention of viscera and it is giving a support. It is formed by the union of the 2 levator ani muscles. Again when we later on go into the surgeries for prolapse, then there is a role of this fascia. And this is known as arcus tendinous levator ani and this is a thickened portion of obturator fascia. It is attached anteriorly from the pubic rami and posteriorly to the ischial spine. And there is also arcus tendinous fascia pelvis which lies anteriorly to this arcus tendinous. You can see here. Now coming to the perineal body, it lies between anal opening and the vaginal opening. It is a fibromuscular node and it is made up of, also known as the central tendon of perineum, made up of 10 pairs of 10 muscles. These are the muscles which contribute to the perineal body. Then again there are the endopelvic fascia condensation in form of various ligaments. So cardinal ligament, McEnroth's ligament, and there are pubocervical ligament. All these ligaments, they are the supporter. Uterines, they give support to the pelvic viscera and the uterus and the vagina. And this is very important when we deal with the support, Delaunay's classification of pelvic support. So there are various fascia also in the perineum and there are a lot of spaces in the perineum. So Delaunay classification, it is important because nowadays when we are dealing with the surgery of the vaginal prolapse, we have to divide the vagina into 3 parts. If there is a weakness in the apex, if there is a weakness in the middle part, or if there is a weakness in the posterior compartment. So accordingly, you have to plan your surgery. So apical level 1 support is provided by the cardinal and the uterosacral ligament. Level 2 support is that support the mid vagina and it is provided by the arcus tendinous fascia pelvis and arcus tendinous fascia pelvis. And the last one, it is supporting the vagina and it is provided by the perineal membrane. Now, what are the functions of the pelvic floor? We all agree that it supports the abdominal perineal viscera. It provides the resistance to increase in the intra-abdominal pressure, and finally, it is also providing the urinary and the fetal continence. So these are the risk factors. Again, pelvic floor dysfunction, it is a multifactorial, and the picture shows these are the various Risk factors, nowadays they classify into obstetrical risk factors and the non-obstetrical risk factors. And the main thing is that if there is a weakness of the pelvic floor, it leads to the pelvic disorders in form of urinary incontinence, fetal incontinence, genitourinary prolapse, chronic pelvic pain, and sexual dysfunction. So we are discussing all these. Our international faculty is highlighting the importance of all these pelvic floor muscle and how to take care of them. Now coming to the ureter. Ureter, again it has got two parts, abdominal and the pelvic. Abdominal is from the renal pelvic iliac vessels and pelvic is from iliac vessel till it is inserting into the bladder. So we are all aware there are important sites of ureteric injury and the course is very important. So near this thing, it is 1.5 centimeter. It is lying 1.5 centimeter and it is crossed by the uterine artery. So it is also known as water under the bridge. This is the UG classes. Our teachers are teaching us how to. This is the mnemonic, and at the level of at the level where the uterine artery crosses, there is important site of injury also. So most common site of ureteric injuries when it is there infundibular pelvic ligament, when the ureter runs just medial and inferior to the ovarian vessel. Second is at the level of internal os, when the ureter is crossed by the uterine artery, and the ureter, and last but not the least, when it is entering into the trachea. So bladder neck, it is located at the level of internal urethral meatus. It is around 3 to 4 centimeter behind the midpoint of the sacral symphysis pubis. And bladder is freely mobile, but it is attached at the level of bladder neck by pubocervical ligament. So we talked about this bladder, and if you consider that bladder is just like this, superior surface, in base of the bladder, which is, there is 3 opening at the base, and this is the apex of the bladder, but once the bladder is distended, it becomes a spherical. Now coming to the anatomy of the rectum, it is around 15 centimeter in length, and we know that the rectum and the vagina, there is a fascia that is known as the Denonvillus fascia, which separate the rectum from the vagina, and the peritoneal relation is that upper 1/3 of the rectum is covered by peritoneum both anteriorly and posteriorly, middle third is covered by peritoneum only anteriorly, and the lower part is not covered by peritoneum. Now the anal canal, it extends from the anorectal junction, which is at the level of pelvic floor, to the anal verge, 4 centimeter. It is divided into 2 parts by a line that is known as the pectinate line or the dentate line. The portion above and the anorectal angle is formed by the puborectalis, which forms a sling, and in resting phase it is 90 degrees. Now this is very important, division is very important when we go back to the development of the anal canal. So अभी आगे मैम discuss करेंगे embryology. So embryology में ये जहाँ पे pectinate line है, there is a transition. So that is known as upper anal canal, that is above the pectinate line, and it is lined by the columnar epithelium. Below the pectineal line, the origin is endodermal. So the longitudinal muscles of the rectum, it extends into the anal canal and end up into the thin septum that penetrate into the puborectalis and external anal sphincter. And longitudinal muscles of the anal canal is also referred to as conjoint tendon. So this is the diagram. You see that the circular smooth muscles of the rectum is continuous with the circular muscles of the anal canal, and the external anal sphincter is formed by subcutaneous tissue, superficial and deep muscles. Now the sphincteric action is provided by internal anal sphincter, external anal sphincter, and puborectalis. Finally, I want to conclude that understanding the anatomy and function of the pelvic floor, genitourinary and anal canal is essential for diagnosing and managing pelvic floor dysfunction. Secondly, early identification and intervention can definitely improve the quality of life for better outcome of the women suffering from urogenital problems. Thank you. Thank you.
Thank you so much, Nasreen ma'am, for briefing us with the anatomy. I would now invite Dr. Afshan ma'am to start with her presentation.
Can you hear me? It's better now, isn't it? So the first talk is about embryology and congenital anomalies of urogenital system and rectum. And I have made it very, very simple, nothing to worry about, because embryology is such a vast subject, as we were discussing, that if you go into details, you are lost. Because this is amazing, up till this day, we cannot even imagine how these things were created. Because this is such a fascinating field, and it is so difficult to understand. You can spend a lifespan and you may not understand embryology. So that's why I've made it extremely simple. It's very few slides and there is nothing to worry about, okay? So let's see. So what we are going to see, what is the overview? Very, very simple. Everybody can understand. Embryological development, urogenital system embryology, that's what we are focusing mainly. Little bit about rectal development. Few nice pictures about congenital anomalies in the urogenital system, congenital rectal, anorectal anomalies, and clinical implications and summary. And it's very, very brief, so nothing to worry about. First of all, let's start with a very basic thing, which is how does it all start? And it is amazing that nature has given it a lot of importance, because all the important things start in the very earlier phase of embryological life, very, very early age. Gradually there is finishing touches, like all the cosmetic bits and all that, but the important things, they start in the very beginning. If you keep that in mind, you understand that obviously heart is the first thing, the heartbeat, it all starts from the heartbeat. But if you think about it, it starts in third to fourth weeks of early gestation, and 3 germ layers are the most important thing you need to remember. And these are the 3 germ layers which give rise to various structures. So if you have to have a starting point, all you need to remember is 3 germ layers. And we all know the name of the germ layers. Anyone can name it? Exactly, exactly. So intermediate mesoderm is our key point. Okay, we are focusing on intermediate mesoderm, and it is key for urogenital structures. So, and then endoderm is the main one, which forms the gut and rectum. So what do you think about ectoderm? What does ectoderm do? Any ideas? Something important? Anybody louder? So where does central nervous system come from? Something important as well. But because we are focusing on urogenital, so we are not going to detail. But what you can see, early blastula, early gastrula, and late gastrula phases, where we can see starting from blastocyst, and then we go to mesoderm, endoderm, and ectoderm. So this is how it looks like. It's like a jelly bean. It's very, very small, but it has started to take shape of a little human being. So we are focusing on urogenital system. So we are only focusing on pronephros, which makes rudimentary and non-functional part of the kidneys, which is in week 4. Now only God knows why this is there and why it is rudimentary. Because in adult life, normally we don't have any role for pronephros. Mesonephros is the one which is important. It gives us temporary kidney function, which is week 5. And then
Metanephros is the permanent kidney which develops week 5 to 9. This is what we need to remember, metanephros. And then sequential development ensures functional renal anatomy. So it's a system which develops very, very basic system very early on, but it keeps polishing and gradually we get proper kidneys. So ureter and bladder development, again, it is a very simplified photo. Ureters, they arise from ureteric bud of the mesonephric duct. And then bladder develops from upper portion of urogenital sinus. So most important thing for all of you is to focus on urogenital sinus. And then urethra forms from lower portion of urogenital sinus and critical branching and integration for proper drainage. So this is just a very basic overview of ureter and bladder development. And then female reproductive system. So the word you need to remember is M. M for mother. You will always remember M for Mullerian, okay? So it is Mullerian, which is paramesonephric duct. They develop into uterus, fallopian tube, and upper vagina. So wolf is usually male character. So Wolffian duct, we don't have to do anything with that. So Mullerian, M for mother, and now you remember that. So Wolffian ducts are mesonephric ducts which regress in females. So proper duct fusion and resorption are essential for normal anatomy. So what's happening here? Things are being formed, and in ideal situation, there should be no interference of any external factors for them to be made normally. But sometimes there are problems, so things don't go according to plan. We will discuss why that could be a little bit later. So now we are talking about embryology of the rectum, as Professor Nasreen mentioned. Hindgut development, it is a mixture of endoderm and ectoderm, and in the middle there is a line which is cloacal or anal membrane. Normally, these two structures, they fuse and the membrane disappears. But if it doesn't disappear, then problems can happen. We'll discuss that in a minute. But for you to remember, it is an interplay between endoderm and ectoderm. And you notice there is no mesoderm in between, so it's endoderm and ectoderm. We'll talk about it. So hindgut origin is endodermal tissue completely, and cloaca is early common cavity for digestive and urogenital tract. And then urorectal septum, it divides the cloaca into rectum and urogenital sinus, and it's all by the end of week 7, but it's still very, very early. And it sets the stage for normal anorectal development. Let's go ahead. So now we talk about, that was the normal structure development. Now we talk about just very basic few congenital anomalies of the urogenital system. So they arise from disruptions in embryological processes. So what do you guess? What could be the interruptions? When baby is like a tiny, tiny jelly bean inside protected environment of the uterus, so what could be the factors which could disrupt this very fine development? Any ideas? Exactly. So there can be things in the environment which can harm little developing baby, which could be maybe some medication being taken, maybe some infection going on, yeah, maybe some antibiotics being given, rarely maybe some environmental factor, extreme stress, or some other things which can affect the normal development, because this is an extremely sensitive time period. But in addition to that, there could be problems with the chromosomes, yeah. So genetic problems as well, which can happen. There could be some gene mutations which can cause these problems. So there can be multiple factors which can cause these problems. So these congenital anomalies can affect kidneys, ureters, bladder, and reproductive structures. And impact on function may range from asymptomatic to severe to life-threatening. So many of us even don't know, maybe we have only one kidney if we never had any imaging or anything. So many of these things we will never know unless there is a problem and we get some imaging, and then we know, oh, we have only one ovary, still managed to get 4 children. Not bad. So sometimes it doesn't affect the normal function, but sometimes it can be serious. So now a few pictures. So we are talking about renal agenesis, that in the first place kidney doesn't develop, so that's renal agenesis. So absence of one or both kidneys, it may result in compensatory hypertrophy or renal failure. Yeah, but not in every case. Sometimes one kidney is good enough. Hydronephrosis, swelling of kidneys due to urinary obstruction. What could be a common reason for obstruction causing swelling on the kidney? If we are talking about male fetus, yeah, exactly. Posterior urethral valves which block the urethra. Because if you think about it, fetus is all the time drinking all the amniotic fluid, going to kidney, filtering, going to the bladder, and then it's the urine which goes into the amniotic fluid again. But if baby is drinking water but not able to get out, the bladder becomes big and the back pressure goes to kidney, and kidneys they can get very swollen. Recently, we had a case of megacystis. Anybody has heard of megacystis? So I'll give you a scenario, so that will give you the importance of these things and important to know these things. So maybe it was only last month that I was on call. I don't do much obstetrics, just once a month I do one on call. So I start my night duty at 8 o'clock and the consultant before me tells me that this patient has been in labor. She is only 28 weeks pregnant, has been in labor for a very long time, and she is known to have megacystis, which is a large bladder. The baby has died, so obviously we are trying to induce labor so this poor woman can deliver the baby. And patient is not delivering. She is multiparous, she should deliver, it's only 28 weeks baby. Nothing is happening. She has had old induction, she is 6-7 centimeters, baby is only, actual baby is small. So the consultant does the scan and he said, oh, it's 1 liter of urine in the bladder. That's why, very big tummy, so baby is not coming down, it's a breech baby. He puts a needle in the bladder and drains all the urine. He said, problem solved. So, no problem, now she should deliver. And now 6 hours have passed after that and again she has not delivered. So now I start my duty and I have no clue because I don't do much obstetrics. So I examine the patient and what I feel, it's a breech baby, but what I feel inside the cervix is like a balloon, exactly like a balloon. In a short period of time, because of all this high placental blood flow, baby's kidneys actually, they had produced a lot more urine before the baby died. It was not 1 liter, it was 2-3 liters. So what I can still feel that it is still megacystis and there is no point trying more unless we drain it. So I just went through vaginal approach, made a little nick in the bladder, drained 2 liters of urine and within minutes patient delivered. So meaning to say such a simple thing, otherwise this patient would have been in labor for another maybe 24 hours or she would have ended having cesarean section. So megacystis is a condition which happens once in many thousands, but I happen to see it. So this is a good take home message that any congenital anomaly can come to you, you have to keep that in mind. Okay, then it makes it easier. So vesico-urethral reflux. So again, posterior urethral valves and then pressure goes back to kidneys and hydroureter hydronephrosis can develop. That was just a brief one. We'll go again to kidneys in a minute. So we are talking about Müllerian duct anomalies. Remember, Müllerian, mother, and it's all female genital tract. Results from improper development, fusion, or resorption of the Müllerian or paramesonephric ducts during embryogenesis. It can cause menstrual irregularities, infertility, recurrent pregnancy loss, and obstetric complication. So you can see it is quite a serious stuff. Okay, so maybe you all might have encountered some of these anomalies, but this is something quite serious stuff going on. So what could be these anomalies? Uterine anomaly, we are talking about MRKH syndrome, where there is no uterus and there is no upper vagina. What a disaster for a female, yeah? So she has no uterus, she has no upper vagina, but she has normal ovaries. So what could be the presentation? Presentation will be primary amenorrhea, managed with vaginal creation or fertility counseling. So now we all need to know what is puberty and how do we define primary amenorrhea when a girl should start period. So in order to define that, we need to know TMS staging, which is a Tanner's classification, that the puberty, 5 stages of puberty, level 1 to level 5. Level 1 starts with just the development of the breast bud, and level 5 is when the actual menstruation happens. So, primary amenorrhea we define when a patient has had stage 1 development or stage 2 development, which is just development of breast bud and just little bit more development of secondary sexual characteristics. So that is, she has entered that. That can start from age 8 till age 13. But if 3 years have passed from stage 1 and there are no periods, that is classified as primary amenorrhea. We should never think, oh, this girl is still 12. We need to wait 17 or 18. Still there is time. Some people just have delayed period. It's not like that. Because in order to save the girl and her mother from all this trauma, we need to understand that from stage 1, which is the first development of breast bud, it is 3 years we can wait. If 3 years have passed and there is no periods, we should label it as primary amenorrhea to save the agony of all that which can happen to the whole family. Or irrespective of all that, if a girl has crossed age 15, has no periods, we can also label her as primary amenorrhea rather than waiting a bit longer. Sooner the better. Okay, so we are talking about MRKH. The ovaries are normal, so all secondary sexual characteristics will be normal. But there are no periods, unfortunately, because there is no uterus and there is no upper vagina. Lower vagina may look normal. So could be huge implication with vaginal creation. So functionally she can function as a female, but obviously fertility is a problem. Unicornuate uterus. I think the commonest thing we all see in other practice is the heart-shaped uterus or bicornuate uterus or septate uterus. So these are fairly common. Maybe all of us have seen a case of 2. But sometimes it's unicornuate uterus. One side goes missing. There is only one ovary. No problem. If the vagina is patent and ovary is working, usually there is no problem. But sometimes there is a rudimentary horn on the side of a normal functional uterus. So that still has got a lining. So when there will be periods, if it is blocked, it can cause a lot of obstruction. It can cause a lot of cramps and can cause problem with obstructed labor as well. So leading to dysmenorrhea and pregnancy complication. Something happened? Light? Maybe disconnected. While this is getting sorted, we can talk about imperforate hymen and imperforate anus, because these are also quite common. Yeah, imperforate anus, we will not see that because when a baby is born usually, because it's not compatible with life, isn't it? It needs to be opened up. So usually they are taken by surgeons and they fix it quite quickly if they have access. So we can talk about imperforate hymen, which can be obviously neglected and it can present with primary amenorrhea. Again, it's a rather commoner problem. Sometimes there is pinpoint hymen and sometimes there is various malformations, can be managed very easily. Just a cross-shape incision, periods can be drained very easy, but should not be taken lightly because can be associated with other abnormalities. Just drink some water. क्या इंटरनेट पे odd, but it will do the job, so no problem. Septate uterus, if septum is little, again no problem. But if septum is a bit bigger, could be problem with early miscarriages because surface area is small. Bicorporeal uterus, hemiuterus, aplastic uterus. So obviously there are other abnormality as well, again because of Mullerian duct fusion and resorption system. Now we talk about congenital anomalies of the cervix. So in the first place, it doesn't form, which is cervical agenesis. Cervical hypoplasia, cervix is there, but it's very, very small. Cervical duplication, surprisingly, this is quite common. We have seen quite a few cases where there are two cervices, all associated with Mullerian abnormalities. Back to kidneys, an interesting slide, various types of abnormalities which can happen. It's a good slide, you will all have handouts. So again, a pictorial representation of various problems kidneys can have. This is an important one for all of you, particularly to work in obs and gynae. So the normal hymen we can see, and there are various annular hymen, imperforate, microperforate or septate, and fairly common problem. Sometimes labial fusion and labia majora hypoplasia, and asymmetry of labia, very, very common thing. We don't take it as an abnormal. In the NHS, if somebody would say, oh, my labia is a bit asymmetrical, can I get it symmetrical? It's not allowed. Any changes which are cosmetic, they are not allowed, they are not funded on the NHS, and sometimes they come in mutilation, so we have to be careful. But I don't know whether it is regulated here or not. People can have designer labia or something.
These days, gynae cosmetology is becoming very popular.
Fashionable.
We don't.
Yeah, that's the right thing. Yeah. In NHS, it is very, very controlled. You cannot do any of these. Comes under cosmetics and it's not allowed. Okay, vagina, congenital anomalies of vagina. So longitudinal septum could be a problem. Obstructive hemivagina with the rudimentary part, and transverse septum, again problem as imperforate hymen. So various types of abnormalities. The take home message is to keep everything in mind, the possibilities of these abnormalities, and to reassure patients, it's okay, these things happen every now and then, and something can be done about them most of the time if it is a structural problem. So uterus diadelphus. So what happens? Actually, there is failure of Mullerian duct fusion resulting in two uteri and two cervices, may cause recurrent miscarriage and preterm labor. So you have to remember these two things, recurrent miscarriages and preterm labor. So it has clinical implication. Bicornuate uterus, what happens? There is partial failure of fusion leading to two endometrial cavities. Again, higher miscarriage and preterm birth rate. Do we have recurrent miscarriages clinics here? Yeah. So something to keep in mind. Septate uterus, most common anomaly. That's what I said, the heart-shaped uterus, 35 to 40% of the cases, failure of septum resorption associated with recurrent miscarriages and managed with hysteroscopic metroplasty. So we are talking about vaginal septum, longitudinal and transverse imperforate hymen. This is repetition. And again, we are talking about cervical agenesis, double cervix, cervical stenosis. Again, we are repeating the same thing, imperforate anus, anal atresia, again managed by colorectal colleagues, not by us. But the main thing for you to know is rectovaginal fistula, because it can happen as a congenital malformation. Because we often think it is as a result of obstructed labor or gynae surgery, but it can happen congenital anomaly as well. So there is abnormal connection between rectum and vagina, and can develop obviously developmental factors or acquired condition. So these are some of the pictures, and one interesting condition is caudal duplication syndrome, where everything is two uteruses, two vagina, two cervices, and complete hindgut duplication. Does anyone know the association of caudal duplication syndrome? It's one of the commonest disease in India. So India is said to be the epicenter of diabetes. Yeah, it is the world leading country in diabetes. So much diabetes is here. So there is association of caudal duplication. So all of you need to know about this. So in mothers who have diabetes, their babies are more prone to caudal duplication. clinical implication and management, prenatal ultrasound, postnatal imaging and clinical examination, surgical intervention like repair of imperforate anus or fistula or imperforate hymen, long-term monitoring for renal function and reproductive health, especially if it is a male fetus, because the posterior urethral valve, they are fairly common. Counseling, early detection and MD care. We are really there. Embryological processes are critical for normal urogenital and rectal development. Disruption leads to spectrum of congenital anomalies. Early diagnosis and tailored management are key to optimizing outcomes. Thank you very much.
Can I say something? We see the congenital anomaly cases, Mullerian duct anomalies very often. And we have been managing these cases, and all of us have witnessed almost all type of cases, rudimentary horn with functioning endometrium, non-communicating, communicating, and all those things. But my one question, as all the seniors of gynae department who are really good in their work, they are sitting here. If we get a case of biconjugate uterus or septate uterus, when should we decide that we should offer them a management? Unification or septal resection? And I think Shaheen will be more than happy to answer this.
Actually, if the patient is asymptomatic, not having any problem, there is no
No
need to
need,
go
yeah.
for any intervention. If she is having any problem, then we should go for
What problem?
Like
Any problem defined that though?
recurrent RPL, or if she is not conceiving.
So if she has one
Implantation
If
failure.
she has one first trimester abortion, then what should we do?
Actually, nowadays we won't wait for 2 or 3 if she diagnosed with a septal.
One or
complete
yeah,
septum.
septa and one abortion.
And we have the
First trimester.
We have the facility of doing the septal resection with the hysteroscopy. I think I will
With
go
one,
for,
we should go for it.
I'll go for it. I won't wait. She should have at least 2 or 3. Then I'll decide for septal resection. But if we won't have facility and she cannot afford the treatment,
Then Shaheen, my question is like, as we know that most of the first trimester abortions are due to chromosomal abnormality, and anyway 15 cases out of 100 are going to abort in first trimester, and the one who have first trimester abortion are fairly possible that they will have a normal outcome in second pregnancy. So how should we decide at that point of time that with one first trimester abortion, we should take a decision of doing a septal
actually, we
resection?
will not diagnose the septum. Actually, for diagnosing, we should go for 3D or 4D. Nowadays, I think 40% of gynecologists is having 3D ultrasound. And they just do the 3D part and they detect. If they have the facility and patient want to go for septal resection, yes. Otherwise,
If she has left it on you, what will you do? Like if she has left it on you with one first trimester abortion, what will you do?
I will not go for any investigation. It may be
It came out to be a septate uterus because she had an ultrasound while she was pregnant, and they said that it is a biconjugate uterus, although it was an abdominal. Now with her endovaginal sonography, the diagnosis of a septate uterus is made.
Actually,
and she has been advised MRI, further investigation.
Actually, with normal 2D, it is very difficult to diagnose septate uterus. 3D is required. And if she has gone for that, like higher center, just for one abortion, I think that counseling is required. So, after 2, even with the septum, with the biconjugate uterus, first trimester abortions. Usually the second trimesters are more with these anomalies, but the first trimester abortions patient may develop first trimester abortion.
Yes, I do remember, and your patient had 13 abortions. By the time she reported to her, already she had 12 or 13.
13 and after
Very
the septal resection, she conceived and delivered.
And she delivered also.
And I think in last OT, she came with a 5 first trimester abortion, and it was a just biconjugate uterus. Ideally, we should go for metroplasty, but I did the partial metroplasty with the resection only with the like 2 cameras with laparoscope and hysteroscope, and now you'll see the result. There may be a chances of rupture during pregnancy if we are doing some like intervention in bicornuate uterus. Even we'll go for metroplasty, it increases the rupture chances.
Exactly.
So with the conservative, I tried. Let's see what will be the outcome.
Would you like to
add one point only, because there was a discussion going on that with one abortion you can wait, not to go for other investigation. But I think if we have to take into account the other factors as well, like in this era of the more the females are pursuing their career, so they are of advanced age. So if she's age is more than you have to, it's one abortion, then she should be investigated.
Yeah.
That is my question.
So that's a very valid point. In the UK practice, there will be no investigation unless there are 3 recurrent miscarriages. No investigation at all, because resources are very precious.
These are
So-
the cases which certainly puts you under dilemma.
Exactly.
Yeah.
Yeah. So 3 miscarriages only, then they get referred to recurrent miscarriages.
Provide efficient, then of course
Yeah.
it's a threat.
Yeah. So when they have
Anything that you have to consider, like the gestational age, the
exactly.
time of abortion,
Yeah.
everything.
Yeah. But in the 3rd miscarriage, the products will be sent for cytogenetic analysis with the 3rd miscarriage. So when they go to recurrent miscarriages clinic, result is available if there is any mutation or anything.
Now, Ashley said it's after 2 abortion
Okay.
you should go. Nowadays we are going, we start investigating the patient after 2
Yeah,
abortions.
that makes sense. Three can be very traumatic, but that's how it is in the UK. So
But now with the era of ERT, even with the implantation failure, we are being considered as if the patient is, there is a problem with the there is no implantation after 2 embryo transfer, so we start investigating the patient accordingly.
yeah, that makes sense. But metroplasty itself is a very traumatic surgery, and itself can result in infertility.
Infertility, yeah.
Exactly.
So that's
Exactly.
why
Adhesions, Asherman syndrome, you name it. Okay. So is there any questions from the audience about anything we talked about? And don't feel shy, you can ask in Urdu or no need to be shy. No questions?
You told that in your slides that the bilateral kidneys are congenitally absent. That is not compulsory.
Yeah. So we were just discussing the spectrum. That could be serious anomalies not compatible. Yeah. Yeah.
These days we are,
Exactly. Yeah.
these days we are able to diagnose so many things in intrauterine life.
Yeah.
Previously they used to diagnose it later on, but now almost
Things
most
are
of the
getting
things
better.
are diagnosed.
Unless patients are completely unbooked, as it could be in your practice, isn't it? Okay, shall we move to the next?
Even if they are unbooked, they will have an ultrasound.
Okay.
These days it has become so rampant. Ultrasound zarur hoga, chahe antenatal visit now.
Okay. Okay, I think considering time, should we move to, let me see which one is the next one. Sorry about that.
नहीं यहाँ नहीं कराएगा, बाहर पीना है चाय।
So now, this is the one next lecture, isn't it? Okay. So should we move to the next topic? Yeah? So we are talking about neurophysiology and pharmacology of the lower urinary tract.
I think we can start, we can have tea.
Yeah, sure.
Tea aa gayi hai.
Yeah. Okay, let's finish this. This is very brief. Yeah. So we are talking about neurophysiology and pharmacology. This is another thing which as students we are scared of, isn't it? It's not a very nice topic. It's difficult to understand. So I've made it very simple. So what do we want at the end of this lecture? That all of you understand what is the neuroanatomy very briefly and very simplified, and we are only talking about in reference to urogenital system, not the whole neuroanatomy, and neural control of lower urinary tract. which we can refer to LUT. LUT is abbreviation of lower urinary tract. So we use that a lot. And also we understand what is the storage phase of bladder and what is the voiding phase. That's all you need to understand. What is the storage phase, what is the voiding phase, yeah? Understand key neurotransmitters and receptors involved in LUT function. LUT means lower urinary tract. Discuss evidence-based pharmacological and non-pharmacological management of LUT dysfunction in gynecology, and we will refer to RCOG and BSUG guidelines. So, very basic things and relevant to urogynecology. Sorry, busy slides, but it is just the basic anatomy, neuroanatomy. So what we are talking about here, that bladder, urethra and pelvic floor, all these together, they are responsible for storage and voiding phase of the urinary cycle. The integrated function of these components of LUT is dependent on a complex control system. Mind you, it is really complex. In the brain, spinal cord and peripheral ganglia, and on local regulatory factors. So bladder is one of those organs which is very strange. There is no other organ in the body, if I am not wrong, which is controlled at so many different levels from head till our pelvis. So we are talking about cerebral cortex, we are talking about brain stem, we are talking about pontine center, we are talking about spinal cord, we are talking about pelvic subplantar nerve, we are talking about sympathetic system, parasympathetic system, and if this was not enough, the local nerve control as well. So it's a very, very rich organ. But if you look at the bladder, it is such a flimsy organ. It is nothing, isn't it? So that gives it very, very unique characteristics. It is rich in nerve supply, but in structure, it is very, very forgiving organ. There is no other organ which we just injure and repair and it gets along so well without even any scarring. So in a way, it's an excellent organ. Okay, so we are talking about dysfunction of neurology or component of the LUT. They can either produce insufficient voiding and retention of urine or different type of urinary incontinence, complexity in overactive bladder. So all the neuronal control is that when we are storing the urine in the bladder, the storage is good. And when we want to pass it, it should be complete passage of urine. So there should be no insufficient passage, so there should be no retention. And when we are storing, it should be a perfect storage without any leaking. So the bladder has two phases, storage phase and voiding phase. That's all at this stage you need to remember. Failure to store urine can be improved by agents that decrease detrusor activity, yeah, and increase bladder capacity and or increase outlet resistance. So what you have to remember, the name of the bladder muscle is detrusor muscle. The thickness of that detrusor muscle is hardly few millimeter in a normal bladder, and it is very pliable. So if you think about a normal balloon, when we put air in the balloon, it becomes even thinner, yeah, and we can fill more and more air and it will be very forgiving, yeah. But what happens in overactive bladder, there is a problem in the detrusor muscle, so it becomes thicker, so it's not able to distend. So we will discuss that why does that happen, yeah. So that is a problem with the storage phase, and then we will see why the outlet of the bladder, which is urethra, what are the factors which make the urethra incompetent. So urine gives way and people have stress incontinence. We'll talk about it. We will also have a brief overview of the nervous control of lower urinary tract and some of the therapeutic principles. We will talk about common medication which we can use to help. So again, we are talking about neuronal control. It occurs in response to afferent signals from lower urinary tract. It will be a nice pictures, I think, rather than reading from here. We will go on. But what it says all that there are 3-4 levels starting from the brain stem, cerebral cortex, spinal cord and pelvic splanchnic nerve. So when there are injuries or diseases of CNS, only then we come to know that these voluntary control of micturition can be disrupted. So what can be these injuries or diseases which can affect the passage of urine? Any ideas? Very common problem. Stroke, yeah, neuronal disruption. multiple sclerosis, yeah, sometimes Parkinson's, yeah, spinal cord injury. So these are common conditions which can result in disruption of these neuronal signals. Either they result in severe overactive bladder or urinary retention. So we are talking about various neurological conditions briefly, and also problems in parasympathetic nerves, sympathetic nerves, and pudendal, which are local nerves. So let's move on. So this is the anatomy of the lower urinary tract, which Dr. Naseem beautifully mentioned as well. So bladder has detrusor muscle. We have to remember it's a smooth muscle. Any other example of any smooth muscle in the body? Any of the students? Very good. Can we control smooth muscles? No. But bladder we can control, can't we? Yeah? So contradiction. Yeah? And also it can become overactive. Can any other muscle, smooth muscle in the body become overactive? It's different, isn't it? It's a very strange type of muscle, isn't it? It's smooth, but it has some voluntary control. Yeah? And it can be under control, it can be out of control, and it has so many factors which can affect it. That's why it's quite an interesting organ. But what we have to remember that detrusor is a smooth muscle. Internal urethral sphincter. It's a smooth muscle too, and it is involuntary. We are talking about internal sphincter. Where does it lie? At the level of bladder neck. So we can't see it. External urethral sphincter, which is skeletal muscle. So it's different. So where would it be? It is in the pelvic floor level. Yeah? So it is a voluntary muscle. And innervation sources of bladder are parasympathetic, sympathetic, and somatic nerve. Any idea what parasympathetic will do? Would it be storage phase or urine passage? Parasympathetic, would you say? Yeah? And sympathetic? So, easy thing to remember, sympathetic is fight or flight. When somebody is fighting or flight, fight or flight, or worrying about something, they forget about their bladder, isn't it? So that's the easy way to remember. Sympathetic is usually storage and parasympathetic is passage, isn't it? P and S, when you remember. Neural control of bladder, we are talking about brainstem, pontine micturition center, coordinates urination, and cerebral cortex is voluntary control. We all know, oh, is this the place to pass urine? It's not, so we control it by our cerebral function. Spinal reflexes are sympathetic dominance in the filling phase. Okay, so voiding is parasympathetic, which is the emptying phase. So anybody with stroke or spinal cord injury can have retention. Again, we are talking about the level now. What level? Sympathetic control. So as a student, you need to know T11 to L2 is the hypogastric nerve, and then beta 3 adrenergic receptors, they cause detrusor relaxation. So what you have to remember, beta agonist, yeah. So beta agonist is good for bladder because it will help with the urinary incontinence because it relaxes the detrusor muscle, so storage phase is improved. So alpha 1 adrenergic receptors, they act on internal sphincter contraction, and then pudendal nerves, which are local nerves, somatic control, and then external sphincter contraction. So all these are levels of various receptors which act in the blood pathway. So voiding phase is parasympathetic. So remember P for passage, yeah, and then you will remember is parasympathetic. The level is S2 to S4, yeah. M3 muscarinic receptors cause detrusor contraction, and inhibition of sympathetic and somatic nerve is sphincter relaxation. Again, it's a nice picture. You can refer back to it with sympathetic, parasympathetic, somatic, and sensory levels and all the information there. So storage reflexes are distension of the bladder produced by afferent firing in the pelvic nerves, inhibition of detrusor muscle which causes relaxation, increased tone of bladder, neck and urethra, and pudendal outflow to external urethral sphincter contraction. So that is the storage phase. As I said in the beginning, all you need to know, two phases, storage and voiding. And voiding is micturition reflex when the threshold volume is reached. Increase in volume and pressure elicits intense afferent firing, activation of dorsal spinothalamic pathway, And when timing is appropriate, the bulbospinal reflex coordinated by pontine micturition center is activated. So all of you, do you know what is the capacity of a normal female bladder? Any guesses? Yeah? Around 500 mil, yeah? So when a patient has overactive bladder, what is their capacity like? A lot less, isn't it? So what we tell patients that the size of a normal bladder is like a grapefruit. Yeah, it can hold around 500 mils. But when your bladder becomes overactive, it doesn't distend and the bladder muscle gets thicker. So size of your bladder has become like an egg. And that's how you can tell patient why they have to keep going to the toilet, because there is no storage facility. As soon as there is 100 ml is collected, they have to go because urine will not distend, bladder will not distend. So that's how you can tell them when we talk about non-surgical training by Dr. Seema, conservative management, that it is a problem of the size of the bladder. The size actually gets smaller, detrusor gets thicker, and how to make it bigger again, because this is a reversible problem. So that is the most hopeful thing, that it can be reversed. Okay, so overview of the continence mechanism. Bladder stretch receptors are activated. Parasympathetic pelvic nerve stimulation, detrusor muscle initiates contraction, and if it is an appropriate place, there is voiding. Inappropriate place, urethral sphincter gets contraction and there is no voiding. But there could be problems with the voluntary control of micturition, there could be overriding mechanism, and various problems lead to various type of incontinence. If it is urge incontinence, usually the detrusor muscle becomes overactive. That's why it is urge incontinence. So patient goes to the toilet a lot, very frequently, and passes only small volume. And when they are getting to the toilet, before they sit down, when they are getting their clothes undone, they start to micturate. So that is called urgency incontinence. Second one is stress incontinence. There is nothing wrong with the storage phase. They can store urine okay. They pass big volume urine. They can hold it. But when they are coughing, sneezing, jumping, doing exercise, urethral sphincter gives way because it's a problem in the pelvic floor. Reflex damage, remember S2 to S4, when they have nerve injury, spinal cord injury, stroke or any other problems, or some neurogenic conditions, they can have reflux problem. Intrinsic sphincter deficiency like peripheral neuropathy can cause problem. And then paradoxic, which is overflow incontinence, actually there is retention of urine because of various neurological condition, and they keep leaking because bladder is not empty. So now this is one of the conservative management which you will be discussing, Dr. Seema, in one of your talks tomorrow, and it is the treatment using electrical stimulation. Now we are trying more and more to do things which are least invasive. Least invasive means without the use of knife, yeah? Trying to talk to patients or doing things which involve no blood loss or any surgery. So this is something which is really promising, and this we are doing more and more, electrical stimulation. So there can be various places where we can do stimulation, but the most easiest one is called PTNS, posterior tibial nerve stimulation. You heard of acupuncture? Yeah, small needles. So it is similar type of a needle on back of our inferior malleolus. On the posterior aspect, there is tibial nerve. So we put an acupuncture needle, and there is a battery exactly like this. It is attached to their patient, sits there for half an hour session every week for 6 weeks. So that is a stimulation of posterior tibial nerve, and then it improves symptoms by up to 60%. Okay? So that is something which is quite arduous. Patient comes to hospital, there is no infrastructure, there is no facility, and not possible to come every week. So there can be something permanent which is called sacral nerve stimulation. So tiny, tiny battery which can be put in the sacral region, which continuously stimulates sacral nerves, which is called SNS. The benefit of that is it is more than 80% successful. The best thing about SNS is there is no big surgery involved, and it is treatment not only for urinary incontinence, it is also treatment for fecal incontinence. If somebody has double incontinence, this is the best way go forward without using much any big surgery. The only problem is finance because it is quite expensive. The little electrode which you put in the sacral region, it is 8,000 pounds. So I don't know whether someone manufactures it in India. Oh no. Okay, but this is the commonest thing. This is the commonest thing in the UK if somebody has double incontinence. So just imagine a tiny cut there No one knows what you have had, and it treats fecal as well as urinary incontinence. One of the best. Huh? 10 years. Doesn't take very long time. And you have like a little remote like thing with you. For example, if somebody needs MRI scan because it is a magnet and all that, you can turn it off at any time. So it's really one of the wonderful things which changes patient's life. Okay. So we are talking about electrical stimulation here, TENS machine. Okay, so the last point here is about bulking agent. Bulking agents are a little inert material like a gel which we can inject surrounding the urethra, which is one of the commonest things which I do, but we will talk about it in day 3 lecture when we talk about surgical management of stress incontinence. Okay, now this is the stuff which can be helpful in India, okay, because this is medication and we do a lot of medication in India, don't we? So that is one of the commonest things which are easy, cheaply available, but we need to know the side effects and we need to be aware when not to give these medication, okay? So these are quite relevant to you to know that which receptors are there and which medications are related to which receptors. So acetylcholine esterase muscarinic receptors, there is a physiology there, but all you need to know that anticholinergic medication are the most common medication which we use in the overactive bladder regime. Anticholinergic, you need to remember that, okay? And pathophysiology is all there, but all you need to know that anticholinergics are the most successful and the commonest medication which we use, but we need to know the contraindication which we'll discuss, and we need to tell patients about side effects because this is a lifelong burden of medication. Other types of receptors, muscarinic receptors, subtypes, and nicotinic receptors, but that is just academic interest, not much clinical things I'm going to tell you. Alpha-1 receptors, beta-1 receptors, and the one which we are interested here are beta-3 receptors, okay? So what you have to remember, only 2 things. One is anticholinergics and one is beta-3 agonist. So cholinergics are anticholinergics and beta-1s are agonist, which will augment the function of beta receptors, and in cholinergic it is opposite to the cholinergic receptors. So again, it is different types of receptors. Mechanism of action of anticholinergics, as it said, that is the most important group of medication. It blocks muscarinic receptors, particularly M3 receptor. Yeah? And it prevents acetylcholine esterase from binding and thus inhibiting detrusor muscle contraction. So the name of the medication is oxybutynin, tolterodine, solifenacin, darifenacin, fesoterodine, and trospium chloride. Out of all these medications, let's check your basic knowledge. There is only one in this group which doesn't cross blood-brain barrier. So all of these cross blood-brain barrier. We'll talk about why it is relevant. One is the medication in this which doesn't. Anyone knows which one?
Trospium.
Well done. You have perfect knowledge. So trospium chloride is the only medication in anticholinergic group which doesn't cross blood-brain barrier. What could be the relevance of that? The side effects. Yeah, because
Having cerebral stroke and all.
exactly. But the thing is, the common side effect of anticholinergic we are going to discuss are dry eyes, no problem, dry mouth, no problem, constipation, no problem. Not serious side effects. Yeah, but if somebody has myasthenia gravis and you give anticholinergic, they die. If somebody has glaucoma, you give anticholinergic, they get blind. So there can be serious problems. So you need to know these things. The problem is that when we read pharmacology, there is so many side effects that we forget about important things. So if you have to take home message today, the common side effects of anticholinergic, dry eyes, dry mouth, constipation, which is not a problem. We can counteract drinking sips of water, using artificial tears, and taking laxatives every day, no problem. But we must know the contraindication, which is myasthenia gravis, muscular dystrophies, glaucoma, so which can have serious morbidity. Yeah, and long-term use of anticholinergic, because all of them apart from one cross blood-brain barrier. Anybody above age of 60, if they take anticholinergic for long time, which cross blood-brain barrier, it can lead to cognitive impairment, memory problem, balance problem. So you have given a woman a tablet to treat her nocturia, But when she wakes up anyway and goes to the toilet, she falls down and fractures her neck of femur. So a small tablet can kill her. Fractured neck of femur in elderly is a very serious problem. And in UK, because we have elderly population and most of the people are above 80, they live very long. So if I give someone solifenacin, her bladder is better, but anyway, it has given her a balance problem and her memory is declining. So you have done a serious harm to patient, but not knowing that these medication cross blood-brain barrier. So anybody above age 60 or 65, my choice will be only trospium chloride, which is slow release medication, 60 milligram, comes with name Regulin in the UK. So just one tablet, slow release, 60 milligram, and she can have it long term without any effect on memory or cognition. Okay, so different types of receptors and different things, but I have told you all of that. So now we are talking about beta-3 receptor agonist, which is beta-3 agonist, you have to remember. And out of all that group, only one medication is there, which is used in bladder. So it is called Myra-Begron. You must be available here, Betmega. So most important thing you need to know about Myra-Begron, it doesn't cause constipation, doesn't cause dry mouth, doesn't cause dry eyes, but it causes rise in blood pressure. If somebody has uncontrolled hypertension, it is an absolute contraindication. If somebody has controlled hypertension and patient promises she takes her medication for hypertension, this can be given, but when we initiate the therapy, they must have blood pressure monitoring every week for the first month. Every week for the first month, yeah, because it can cause uncontrolled hypertension. So that's one thing about Myra-Begron. Other two side effects are palpitation and headaches. If they promise, they will keep their medication, because you know, in our countries how people choose, oh, today I'm not going to take any medication. So if they don't take blood pressure medication but they have taken Betmega, it can give rise to uncontrolled hypertension, could have stroke. So we need to counsel them. So my preference is not to give them. And the second contraindication is the patient with renal compromise. So people can have Betmega when they have renal compromise, but the dose is half, it is 25 milligram. We never give 50 milligram. The standard dose is 50 milligram, but we give only 25. Okay, we move on. So these are the medication which are used in erectile dysfunction, but they can be used in lower urinary tract problem. We don't use them in gynecology. And then the bottom one is about Botox, and that is one of the medication which changes people's lives. Yeah? So it is a toxin. It's a toxin which we inject in the blood. Do we have it here?
Yes, beauty.
Oh.
Every beautician has
Yeah.
started using
Yeah.
this.
It is very simple and it is something you can start.
People have like very big Indian figures whose face has become plastic-like because of Botox injection.
Yeah, but it has best use in bladder.
Ask my pupils, they should be able to tell the names.
Yeah. Yeah. But in normal, yeah. But this is something which is, it is something which can transform patients' lives. Because in overactive bladder, people go to the toilet 20 times a day, in the night 7, 8 times. It destroys their life. So many people get fired from their job in UK. If you are a nursery nurse and keep going to the toilet every half an hour, who will employ you? You can't be a teacher, you can't be a manager, you can't travel because every services you have to stop. So this transforms people's life because no side effects, 70% success rate, and takes 5 minutes to do it. Flexible cystoscopy and Botox. So we can talk about it in detail, but this is one of the best things in overactive bladder. So these are the medication we were talking about, and I put it separately: dry mouth, dry eyes, constipation, beta-3 agonist, hypertension, palpitation, duloxetine. Anyone knows about duloxetine? Yeah. So what is the relevance here? Why did I put it here? What does duloxetine does to the bladder or pelvic floor? Duloxetine is the only medication which is the medical treatment for stress incontinence. Stress incontinence, the basic treatment is either conservative or surgical. The only medication which can help is duloxetine because it has effect on the pelvic floor, external urethral sphincter. So it increases the tension in the sphincter, so it can improve the holding capacity. So this is a side effect of the medication which can be used for therapeutic use. But in my career as a Urogyne consultant for 11 years, I have never prescribed it. The reason is serious side effects, and I would never prescribe it. But for students, you need to know there is a medication which can help. But as I said, I have never prescribed it because severe cramps, it causes severe nausea, severe cramps, severe diarrhea. So what is the use of being dry when you have diarrhea from other end? So no problem. So yeah, so but theoretical point of view, you need to know. This is the most important thing which can help in postmenopausal women. So bladder, urothelium and vagina and urethra, all of these have estrogen receptors. So when somebody crosses age of menopause, which is usually after age 48, 49, the estrogen receptors are there, but there is no estrogen. So all these areas, they become very, very atrophic, and sometimes all you need is just estrogens, and you do not need any. It is so surprising. It is such a common sense things that local estrogen, vaginal preparations in the form of veggie roots or veggiefum pastries, estriol cream, just 10 microgram every night for 4 weeks and then twice a week for 4 months. So that does the trick, improves urothelium, urethra, vaginal, and I'm sure you have it here. This is something you have. Desmopressin. Anyone heard of desmopressin? What is it? Something to do with antidiuretic hormone? Analog, isn't it? So it is antidiuretic hormone analog. So it works as an antidiuretic hormone. So what happens, this is a treatment for nocturia. If a patient is going to the toilet once in a night, that's normal. More than once is called nocturia, okay? So it's a big burden because some people, they have cardiovascular problems, so in the daytime their bladder is perfectly fine. But the water keeps collecting in the lower part of their body because of varicose veins, because of poor kidney function. But as soon as they lie down, all that water goes back to the kidney, it becomes available to the kidney, kidneys filter and they produce a lot more urine in the night time. So their primary complaint is nocturia, daytime they are perfectly fine. So in order to cure that, we can give them desmopressin, which is antidiuretic hormone analog. But the problem with this is low sodium. It can cause low sodium, and if that happens, they can have seizures. So a minor problem, but can result in serious comorbidity. So anybody we start on desmopressin, they need to have kidney function test every week for first 4 weeks. And if they have low sodium, we immediately stop. And that is the main thing. Otherwise, it's an excellent medication. And always start, if the normal dose is 100 microgram, I always start just from 40 or 50 microgram, not with the full dose, just to see the effect. Yes, this is my favorite stuff, Botox toxin. So what do we do? It's a picture of the bladder with a cystoscope in the bladder. So the needle is like a hair, very, very thin needle. We do it under local in the clinic. So we put the scope in, we have a look that everything is normal, we put the needle in, and we reconstitute. Starting dose is 100 units of Botox with 20 mils of normal saline. We mix it up, but we never shake the bottle. It's a very big molecule. If we shake, it breaks, it doesn't work. So we give it 1 mil at 20 places. So patient cope very well. It's a very fine needle. Starts working in a week's time. We have to tell patient it doesn't work straight away. Takes a week for the toxin to work and paralyze the detrusor muscle. But it can change people's life. This is the favorite stuff. But 100 units is the smallest dose which we start with. If there is no benefit after 3 months, then we can book for 200 units. And if there is no benefit after 3 months, we can give 300 units. So maximum dose is 300. So it's a toxin. Why does it not kill patients? What do you think? The reason is the dose. So the dose which is required to kill a human being is 2,800 units. It's good to know, isn't it? So that we know that never ever to give any dose bigger than that, and we can never give. Maximum we can give is 300 units. A word of caution, it can cause urinary retention, and if that goes unnoticed, they can have recurrent urinary tract infection, big problem. So it needs to be a flowmetry or flow rate or bladder diary should be available if there is any problem. Post-micturition residual volume should be checked if they have recurrent UTI. Yeah? Sometimes we have to teach them self-catheterization if they develop retention. Whenever we give Botox, we give 5 days of antibiotics because risk of infection. So that's all about medication. Sorry, I'm taking long time, but any questions about medication? So if, actually it can last 8 to 9 months. If you give once, and sometimes it can last 1 year. And you don't have to have it lifelong. Patients only need 2 or 3 times and then the habit cycle is broken, the capacity of the bladder becomes bigger and they may not need it again. So it is something really good. Yeah, something to think about here if Botox is available for cosmetic reasons. Any questions at all? Anyone? About the quality of life. Yeah, quality is about quality of life. Yeah, all you need is a scope. Simplest thing. Yeah, yeah. Even the rigid cystoscope, you can put a bridge and there is a needle which is not, because in England we have everything disposable. So we throw the scope in the bin. Next time I will not throw it, I'll bring it here. So somebody can manufacture it. Yeah, yeah. So I have 6 patients in one clinic. So I have six scopes which I use and put in the bin. Yeah. Yeah.
Thank you so much, ma'am, for such an insightful lecture. We really enjoyed. We'll now take a short break and we'll have tea. And we'll meet after 15 minutes. We would now resume our session, and I would request Afshan ma'am to continue her lecture.
Okay, so we will be starting the last lecture before our tutorial, and this is epidemiology and psychological impact of female pelvic floor disorders and sexual dysfunction. It's just a very simple talk again. Of course. Is it better now? Yeah? Maybe shall I use that mic? Maybe it will be easier. Yeah? Maybe they can see me.
I think you can be on the podium.
Yeah, that's what I'm thinking.
You can deliver from there.
इसको off कर दूं?
You can deliver from there.
Yeah. Okay, is it better now? Yeah. So we will start our last talk before our little tutorial about epidemiology. So it has huge impact on quality of life, not only for the patient, but also her family members. A lot of marriages can be broken, and a lot of jobs can be lost, and huge financial impact as well. So it should not be taken lightly, although because there is no life and death, as we were discussing this morning, so these are neglected area for poor countries like ours. Yeah? Because obviously if there are limited funds, they will be allocated to cancer or things which are like orthopedic surgery, maybe cardiac surgery, and quality of life issues are neglected. But now we have come to a stage where women's health should get the center stage as well, because we make 50% of population, and these things should be given importance, because suffering, female suffering is not a suffering of one female, it has impact on the whole family. Because children look at the face of their mother, and if mother is worried, everybody gets upset. It has effect on the whole society, because women are the cornerstone of our society. So this is the right time that we need to give importance to psychological impact. Oh, something is happening again. So we will discuss very briefly pelvic floor disorders usually faced by, yeah.
मेरे ख्याल से ना इसमें कुछ तुम्हारा बार-बार डिस्कनेक्ट जा रहा है। कौन सा केबल? अच्छा। तो ये कौन करेगा सही?
Okay, so we will talk about sexual dysfunction and pelvic floor disorders and the link between them, and prevalence of depression and anxiety in women who have pelvic floor dysfunction. And we will also mention few studies in India done on pelvic floor disorders, and sexual health management versus social stigma, literacy rate, mental health issues. So all of these issues, they affect 50% of the population. And we will mention few studies, I said. So pelvic floor disorders, mostly when we say pelvic floor disorders, mostly we are talking about two things. One is urinary incontinence, and second thing is urogenital prolapse. So they make bulk of the pelvic floor disorders, but there are a lot other problems as well, but they are less common. So we will talk about the frequent problems. So we will talk about stress incontinence, urge incontinence, overflow incontinence, and neurogenic incontinence during the course of this week. But today we are just seeing the effect of these problems on the psychosocial issues. So we will also have a little discussion about fecal incontinence, and it has same impact. So we are talking about pelvic organ prolapse in the course of the next week, the types of prolapse and how do we manage them, uterine prolapse, and vaginal prolapse and vault prolapse, and what is the connection of these to mental health. So this is a slide which was shared earlier in the first lecture, the common risk factors for pelvic floor dysfunction. The main thing is chronic constipation, which is extremely common, and we don't recognize this as a disease factor, but actually it affects pelvic floor a lot. Because of very limited space in the pelvis, so when it is loaded colon, it affects bladder as well as the general pelvic health. So it should not be taken lightly. So chronic constipation must be treated. Second thing is manual labor and heavy lifting. We don't realize whatever we lift, it has effect on the pelvic floor because all the weight goes in the pelvic sling, and with chronic heavy lifting, the pelvic sling gets loose. And the third factor is obesity, that has the same effect on the pelvic floor, and somebody has chronic coughing, that has same effect. And genetics. Can anyone name any condition which can cause pelvic organ prolapse even in nullipara women? Exactly. So two common condition, not common, connective tissue disorders, Marfan syndrome and Ehlers-Danlos syndrome. So I have seen patient like a girl who is like 25 years old, nulliparous, and her uterus is lying outside the body. How disastrous is that? She hasn't even got married or something. Or even if she has just got married, maybe before hymen was holding everything up, and now joint hypermobility and uterus is lying outside. It's an extremely serious condition. So, common condition like bulge in the vagina, giggle incontinence, stress incontinence, urgency incontinence, incontinence during sexual intercourse. So, problem with sexual desire, difficulties in libido, orgasm problems, sexual pain disorders, excitement and arousal difficulties, and all this can be associated, and maybe the main cause is prolapse or bladder problems or incontinence, which results in these types of problems. So, certain studies have shown the link with all these sexual type of problems. We are not going to go into details of this because we are talking more about urogenital physical disorders. But all these studies have shown, all the references there, that it is strongly associated with sexual dysfunction. So again, these studies are talking about stage 3 to 4 prolapse, more likely to cause sexual problems, and the things which we're discussing on the last page. And when we do the surgical treatment, that is the main take-home message, that the sexual disorder can improve. So because the root cause of the problem is in the pelvic floor disorder. Again, the pelvic health is in the center of all these psychological problems, anxiety, depression, body image problems, relationship problems. This is more academic purposes, some of the studies I'll mention here. Emotional strain, effect on the relationship. Financial and career implication, this is mostly in the UK practice, we see this a lot. This is more related to India, stigma and shame. People are not coming forward to discuss these problems, and lack of awareness in patients. Thank you. So access to these facilities, which is pelvic floor health clinic, is obviously a problem here in India. So we are talking about few studies, and there will be references at the end, that the rural population and urban population location in India. So 80% is rural, and literacy rate is low in certain population, and parity is quite high parity in most of the women. So all these factors result in pelvic floor dysfunctions. So why women don't seek help? Because of embarrassment, lack of transportation, financial constraints, lack of family support, and they are reluctant to inform their family members, let alone talking to a doctor. And these are various symptoms with prevalence of these problems in various studies. Again, sexual dysfunction, few references. So symptomatic pelvic organ prolapse remains a common condition affecting elderly female, but they don't come forward. Being a hidden disease and due to lack of awareness as well as because of embarrassment, women neglect their symptoms and seek help only when situation worsens. And prolapse affects quality of life involving bladder, bowel, sexual function, and a multidisciplinary team approach. Obviously, this is what we are trying to develop. This is what we are trying to raise awareness. So pelvic floor physiotherapy concept, which we will discuss in conservative management, that how do we develop a team of physiotherapists to develop this holistic approach. So the lesson is the awareness and empowering patient and promoting awareness. If all of you learn that these problems do exist and there is no shame in discussing, and maybe we can start with each other. If all of you have any problem, you can come forward, discuss with each other, and there is no shame and stigma. And if you need any treatment, and that way you can tell your patients as well, when you talk to them about other health problem, maybe you can ask them, do they have any urinary problem? Do they have any fecal incontinence, any problem with sexual dysfunction? So there should be no stigma. This should be the part of the history for any patients you are seeing for any reason. So there are a few references at the end that there is high prevalence of depression and anxiety in women with pelvic floor disorders. So the cost related with pelvic floor dysfunction, medical visits, medication, surgical procedures, and rehabilitation therapies. Indirect costs are because of low productivity, absence from work, reduced caregiver participation, even simple cost of buying the sanitary towels. If somebody has incontinence and they have to buy good quality sanitary towels, it's a huge financial burden. So what we can do? First of all, increasing awareness, and that's the whole idea of doing this workshop. Early intervention, to pick the problem up as soon as possible, and so we can diagnose it and we can treat it. Improved access, develop specialized cares, develop the subspecialty of urogynecology, and then research funding, and then to fight for funding, because here we have to fight for everything, isn't it? To fight for funding, so little research project can be done. For example, comparison of various use of various pessaries to support urogenital prolapse, maybe Gellhorn pessary, shelf pessary, poppy pessary. There are cube pessaries. So all the pessaries I have brought with me, and one of the sessions we will show you all the various pessaries because things have got quite advanced. So something as simple as a poppy pessary can change a woman's life. Yeah. So we will show you all various types of pessaries, and there are certain pessaries which can be used for stress incontinence. So we'll talk about that as well. Sorry. So applying a life course approach to pelvic floor health, education and information, maximizing opportunities, as this opportunity was seized by Dr. Seema when we met in the UK. Similarly, when you get a chance, seize the opportunity, raise awareness, do something which can improve health of our women, improving capacity in specialist urogyne services, and tackling gynecology waiting list. So these are few references which we use for the studies I mentioned.
So any questions? It was just like a brief awareness session about psychological impact and sexual dysfunction correlation with pelvic floor disorder. Any questions at all? I think this is a subject which is not much talked about, but raising awareness is one of the main things. Okay, thank you. That's all for this topic. So the last thing is, I think POPQ. We will talk about POPQ. If nobody has any questions, no? So I know everybody is tired, so we will talk about POPQ. The very last one, POPQ video. Before we start the video, I will just say a few things before we start. So what is the need? Anyone knows what is POPQ? Yeah, so pelvic organ prolapse quantification system. So what is the need for that? The problem is urogynecology is a field where a lot of research is going on, and we need a certain system of quantification of our findings which are comparable and which are relatable to each other. For example, if I see a patient and I examine her and I tell you, oh, she has moderate cystocele. Maybe next week you will examine her and you will say, actually she has got a large cystocele. And somebody else will examine and tell her, you have got a small cystocele. So there is no reference point. So no research can be done because we cannot validate the examination findings. So in order to tackle that problem, a numerical quantification system has been developed, which is called POPQ, Pelvic Organ Quantification System, and it's a numerical system. So in order to develop a numerical system, we have to have a reference point which is fixed and which doesn't change with the prolapse. So there are 2 points there in the vulva which do not change whatever happens. And one is external urethral meatus, which always stays the same place. And the other one is hymenal remnant. So these are the 2 reference points. So we use in the POPQ as station 0. So if there is any finding which I say station 0, this means that part of the vagina or uterus is reaching either to external urethral meatus or hymenal remnant. If with any reading there is a plus point, for example +3, this means it is 3 centimeter outside the hymen. If it is -3, this means it is 3 centimeter inside the hymen. Yeah? So the POPQ is a 9 boxes grid. But the very easy way to understand, because it's very, very confusing, I'll just draw it. And we will see a video which will explain it better.
सबको दिख जाएगा तुम आगे
We will see a video in a minute. So all you need to remember, as we were talking about basic and simple things which you remember. All you need to remember, this looks very complex, but in order to simplify it, these 3 readings, just imagine, this is vagina, this is uterus and cervix. So just imagine these 3 readings are anterior vaginal wall. So if you keep that in mind, everything becomes simple. These 3 readings are the middle portion, yeah, which is uterus, cervix, and the point we are mentioning is 3 centimeter inside from the hymen. If it is +3, this means it is 3 centimeter or 2 hymen. If it is +3, this means it is 3 centimeter or 2 centimeter or 1 centimeter outside the hymen. So in order to simplify, if you see that we don't have much time in clinics, we cannot keep filling all these 9 reference points. So what I'm going to do, I'm going to show you a video, and then I'll tell you simplified POPQ, which I have made it myself. So instead of 9 readings, there are only 3 readings. But it gives you equally descriptive mention of the front wall, middle wall, and all that. So I'll mention this, but I'll let you watch the video first. So now we can play.
Hello, my name is Fiona Beach. I'm a urogynecologist I'm going to explain the POPQ grading system for pelvic organ prolapse. This stands for Pelvic Organ Prolapse Quantification and is a site-specific tool to describe pelvic organ prolapse. Some centres use it as part of their day-to-day assessment, but it is also very important as a research tool as it's reproducible. There are 9 measurements in total, and these are recorded on a grid. 6 relate to specific points in the vagina, and they are measured with respect to the hymen. If they lie above the hymen, they're given a negative number, and if they are below, they're given a positive number. AA is the point on the anterior vaginal wall that is 3 centimetres proximal to the hymen. So this could be recorded as -3 all the way down to +3. BA is the most distal portion of the remaining upper anterior vaginal wall. So this could be -3, but it also could come all the way out to +5, 6, 7, or even more in extreme cases. AP is the point on the posterior vaginal wall, 3 centimetres proximal to the hymen. Again, this could range from -3 to +3. BP is the most distal portion of the remaining upper posterior vaginal wall and can range from -3 to 6, 7, 8 or more. C is the most distal part of the cervix or vaginal cuff scar if they've had a hysterectomy. So this could have a big range around -10 or could come down to 7, 8 or even more. D is the point in the posterior fornix, and this is often 2 to 3 centimetres above point C, but sometimes the cervix is quite flush with the posterior fornix. This is excluded if they've had a hysterectomy. GH stands for gentle hiatus and is measured from the middle of the external urethral meatus to the midline and the posterior hymen. PB is the perineal body and is measured from the posterior portion of the gentle hiatus to the middle of the anus. And TVL is the total vaginal length, measured when point C or D are in their normal place. When you examine someone, you can measure each point and record it in a grid, so it's easy for the next person to see what prolapse is present. This is useful for when comparing pre- and post-operatively. So we can have a look at some examples. So here is a cystocele, where point AA and BA are both at 0. Here is uterine descent, where the cervix is at -1 and D is at -3. Here is a complete vultiversion, which shows that AA and AP are both at +3, so as distal as they could be. It shows that BA and BP are at +7, which is the same as point C. In this case, there's no uterus, so there's no need to record D. I hope that this has made POPQ a little clearer, and I have more confidence to assess women with prolapse.
So we were talking about simplified version because if you look at it, it can be quite nerve-wracking. So instead of 9 readings, we can just have 3 readings. So we can have BA, C, and BP, and then TVL, 4 readings. So BA is the leading most part of the anterior vaginal wall. For example, if somebody, I would say, +5. So what it will tell me, it's a huge cystocele. Yeah? So I'm using only one landmark, which is the leading part of the anterior vaginal wall, which is BA. For example, I say +5, and along with that, she has procedentia, so whole of the cervix and everything is lying out. For example, I say it is +6, and then BP, she has a rectocele as well, so I would say maybe it is +1. And when I reduce it, the total vaginal length is still 8. So if I have written this in my notes, I know this woman has got a large cystocele, uterus and cervix are almost out, and she has got a small rectocele, but still total vaginal length is 8. So I know there is more readings, for example, genital hiatus, but that doesn't matter, and perineal body, that also doesn't matter when we are describing prolapse. Because we need to know that leading part of the anterior vaginal wall, leading part of the cervix or cuff if they have hysterectomy, and leading part of posterior vaginal wall. So this is a simplified version. So if you see any of my letters for my patient, instead of 9 grid, I only use these 4. So this makes my job quicker, and everybody can understand and relate to it. So after I started using it, all of my colleagues and everybody in our department, everybody uses only description of POPQ, like these 4 points, because this is a simplified version. Because it tells you, for example, if I write BA minus 3, C minus 7, BP minus 3, TBL 8, this is a perfectly normal vagina with no prolapse at all. Everything is where it should be. So that's how it should be. But if it is this is extreme prolapse. If it is a vault prolapse or procedentia, it could be C plus 10. Yeah, if it is procedentia. So something like that. So this is my simplified version. I hope it's a bit easier to understand POPQ now. Okay, any questions now about POPQ or anything else? No? You want to say anything? Sorry? Yeah, so point D. Yeah, it will be point D. And then it is usually not isolated, isn't it? So that will be most like BP, which is the posterior vaginal wall. This is the one which is the leading part of the posterior vaginal wall prolapse. So maybe it will be +5 or something, whatever it is. So if we are talking about BA, that is the lower part of posterior wall, but we are talking about BP, which is the upper part of the posterior, so which can be description of enterocele as well. BA. So A or posterior, yeah. Yeah, so we are only simplified version. We are only talking about the leading most part of, because from practical point of view, it doesn't matter what we are interested, what is the leading part of the most dependent part of the prolapse, because that's what we have to deal with. Yeah? Yeah. 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 So obviously every patient is quite a specialized person, isn't it? So findings will be different for each patient. What here we are trying to do, we are trying to do a generalization for easy understanding. But if you want to do a complex monitoring, you can do all 9 grids if it is a patient which needs description. But in order to make these things simple, because everybody is scared of this, isn't it, POPQ. So what we are trying to do, we are trying to make it simple so everybody can understand. But if you want to do complete 9 grid, obviously you can do that as well.
Anyway, before we take a decision to operate and she's symptomatic and we have to operate, we have to evaluate her completely. And as we are discussing, that enterocele has to be ruled out.
Yeah.
In every case of prolapse.
Exactly.
Before we decide, because the enterocele has to be taken care of.
Because unless there is apical support, prolapse surgery is not successful.
Yeah.
That is a take-home message when we discuss prolapse.
And even if enterocele is not there,
yeah.
Even if it is not there and we are doing a vaginal hysterectomy for prolapse, we do a McCall's chondroplasty
Exactly.
in order to prevent all sacrospinal fixation.
Yeah.
Whatever, like we have to do something so that it does not happen in future. Only thing different will be if there is enterocele, we'll have to take care of the sac. We have to dissect the sac and then ligate it and then do the same thing. Yeah, missed it.
Exactly.
Missed enterocele.
Yeah.
Because you have to decide the remaining part of the sac.
So the recurrence of anterior vaginal wall prolapse, the recurrence rate is 33%. The reason is because we miss the apical support. So we have to do something at the apex, otherwise prolapse surgery will never be successful, especially with large prolapses and the one with the apical support. Okay, thank you. Thank you very much. So that is called site-specific prolapse repair. Because it depends, most of the reason of prolapse is usually childbirth injuries. So if it is odd position of the baby's head, or if the forearm is coming or elbow is coming, and it has destroyed a specific part, or if you have used forceps and the blade has destroyed a specific part, rest of the part is intact. So we need to do thorough examination in lithotomy and sideways to identify that part. And then we can open that area and do site-specific prolapse repair. Not necessarily it has to be midline fascial plication as we do. It has to be site specific. So again, that will depend on the patient's.
Sometimes when we are doing a punch rectum examination, we see the lateral vaginal walls. They are very clear. They are coming.
Yeah. So in that case, if the total vaginal length is adequate, which is like 8 centimeter or 9 centimeter,
If it is not a short scarred vagina, in such cases sacrospinous fixation could help, because it will extend the lateral wall to the sacrospine. So I think that will be a good idea along with site-specific repair. It's quite a helpful discussion. Any other questions? We will be discussing in the rest, because this was only basic science.
As it is based on the topic is anatomy, which is relevant
Yeah.
to site-specific management through manicuring and so if when we are planning to do a sacrospinous ligament fixation, we can discuss that how to go, from where to go in the posterior vaginal wall, so that we exactly reach to that point.
Exactly.
In the pelvis we can have a demonstration, I think.
Yeah. So the main thing we need to know is the spines.
Manicure this way. See, where are the can I demonstrate?
Of course.
Yeah. Where are the sacrospinous ligament attached? Any PG. Come and show me where is the place of attachment of sacrospinous ligament. Come, Supriya. Tell us where is the sacrospinous ligament attached. Promontory. Ischial spine बताओ कहाँ है? Ischial spine. चलो ischial spine बताओ, आराम से देख के, ये है। और sacrospinous ligament कहाँ किसके बीच में होगा? ischial spine और sacrum के बीच में होगा, ठीक है? इसके बीच में होगा ना, लेकिन हमें वो ligament मिलेगा कैसे? How to reach to that ligament so that we are able to put in the stitch and to do the plication. Very good.
Well done.
First thing is we will palpate the ischial spine. Say it loudly. We will palpate the ischial spine. Then what next? But how to reach there, beta? It is very deep. Ligaments are not superficial. So how to reach there? Say what? How I do? The best way to reach to that area is see the posterior vaginal wall. Okay? Seen it? See where is the middle third of posterior vaginal wall is located. Okay? ऊपर होगा, नीचे होगा, middle part होगा. After locating that area, take a 3 to 4 centimeter vertical incision on the posterior vaginal wall. Okay? Can you imagine you are seeing a posterior vaginal wall here and middle third you have located and given a vertical incision. Okay, but before that, what we do, we adrenaline solution, but don't put too much of adrenaline solution. Just 20-30 ml in that area is enough. Why? Because that is going to protect the organ from any injury. Rectal injury nahi hogi if there is a fluid between your rectum and vagina. After giving that vertical incision, do a dissection. Kidhar jana hai, left or right? Where are you going to dissect? Where is rectum situated? Left, isn't it? So where do you want to go? I think I am loud enough. I am loud enough because these things are disturbs. So where is rectum is on the left side? So usually right side sacrospinous ligament fixation is easy, number one, easily done and there is no risk of injury to rectum. One side is enough to take the vagina up and place it normally, right? So once you have given that dissection, dissect the vagina from the pararectal tissue by sharp dissection. Don't come on the opposite. Left side mat aao. Left, you have given an incision, leave it there. Only on the right side that you will have to go between the vagina and pararectal tissue. Okay?
And once you have gone deep and you have separated the vagina, just do this action of your finger like this. तो तुम्हारा left side है ना, तो तुम्हारे ये, just with your finger keep on separating the tissue and keep on retracting the rectum away from your field. When you will reach the deeper part, that means ligament, before that you will come across few bands like what we call rectal pillar. That has to be slowly dissected with your finger. अब sharp नहीं जाओगे, sharp जितना करना था vagina को अच्छी तरह से separate कर लिया. Now you will have to go like this because जो हमें किधर fix करना है, right side पे करना है ना, तो opposite direction में हमको rectum को right side left side ले जाना है और right side को clear करना है. Once everything goes and your finger has retracted the rectum, put 3 retractor. कहाँ? एक तो ये जो lever retractor होते हैं ना, not very big but medium size or small size, एक से तुम rectum को retract कर दो, ठीक है? One will retract up and the other will retract down. 3 direction हो गए ना, एक rectum हो गया, एक ऊपर हो गया, एक side में हो गया. Now the structure which you will see is that ligament which you will have to pass the stitches through. All right. So very easy to, but not very easy for a beginner, but you can do it if you are in the right plane. But you have to be in the right plane and how to move your finger so that rectum is retracted on the opposite side and your ligament becomes visible. Now once the ligament is visible, there are different methods and Afsha has brought some specific instrument to pass through, but what we do not have that, so we pass the non-absorbable suture first, उससे पास करके निकाल लेते हैं और little how much, like क्या इसके बिल्कुल पास? No, don't do that. Come 2 centimeter medial, ये जो तुमको spine feel हुआ है, bone, उसके 2 centimeter medial, and that ligament from the middle part you will have to take. Don't go up, don't go down. Going up, you will be injuring nerves, and going down, you will be injuring vessels. तो ना हमें nerve injury करनी है, ना vessel injury करनी है, लेकिन ligament के mass से लेना है, ठीक है? Which muscle is in close proximity? Coccygeus muscle. So even if your stitches passes through the coccygeus muscle, it's okay, but your stitches will always pass through the, once you have done this dissection, it will pass through the sacrospinous ligament only. And how will you know that you have really pierced and passed through that ligament? When you pull that stitch, you will really face a resistance कि हाँ ये अच्छी तरह से pull हो पा रही है. Once you pass these 2 stitches, अब क्या करना है? You can do the anterior part, anterior cystocele है उसके साथ associated. अब cystocele के लिए तो एक transverse incision दोगे, वो inverted T, and you have done the dissection, you have taken care of cystocele. Posterior vaginal wall में हमने mid में दिया था, ऊपर transverse दिया, तो बीच में एक bridge of vagina है, ठीक है? It's good that that bridge of vagina is there. Now that vaginal bridge, to pass your finger through that vaginal breach and reach to the most apex part. If you are doing it for wall prolapse, what you do, put 2 stitches. जो wall prolapse का सबसे prolapse part आया है, put 2 stitches on the highest part as a stay suture or as a stitch which will demarcate that this is the apex of your prolapsed vagina. Vault जो भी prolapse है, तुम्हें पता रहेगा ना, मान लो यूं करके prolapse है पूरा, तुमने यहाँ एक stitch लगाई और यहाँ, you know that this is the apex part. So once you have dissected to that point, now these 2 stitches, one was non-absorbable, one was absorbable. The stitch which was non-absorbable, that has to be passed underneath the vagina, highest point. Vagina ke highest point pe underneath that stitches has to be passed. And when we will pull these stitches, the vagina will go up. ठीक है? जो vagina के अंदर से, or that stitch which was absorbable, that can be passed through the highest point, through the vagina, and then tying part has to be done last. अब क्या next करना? तुमने सिस्टोसील रिपेयर कर ली, वजाइना क्लोज आगे का कर दिया, पीछे जो तुमने मिडिल थर्ड काटा था, that vagina you have repaired well. Now the last part you do is just pull these stitches. When you pull, the vagina goes up. And this is really, you will be surprised to see कि जो हमने किया था, it is successful once it goes up. As soon as you pull, the whole of the vagina goes up and then you tie. Non-absorbable and absorbable. Both you have passed through the vagina, one through and through which was absorbable. The non-absorbable has to be passed under the vagina. Never let any part of non-absorbable come into the vagina because that will create lot of problems. So once you have done this, the whole vagina goes up and your surgery is successful. On table only you can know that this surgery is successful. So reaching there, this is the way and this is how you do. Some people give vertical incision, whole vertical incision, and then they enter into the peritoneum cavity. This area is located retroperitoneum. Okay? So we need not to open the peritoneum. So without opening the peritoneum, if you want to reach to the right place, that middle third is the area from where you can dissect and you can reach right there. और कहीं नहीं जाओगे, उसी area में जाओगे. And once, as Supriya has said, that you have to palpate the ischial spine because that ligament will be there at this level also. And 1/3, जब middle 1/3 खोलोगे, so you will reach that. So any point, if it is not clear, I can again repeat it. And those who have seen me operating, I think they can relate it. Naila is nodding because those seeing is believing, and you understand steps once you see. We don't have a proper model on which I can, like on model, although model are very different from human body. There are, so nobody can make a perfect model as a human body, so things becomes difficult, but I hope I have made it clear, and if it is not clear, I can explain it once more. Thank you, Supriya. How nicely you palpated ischial spine. है ना? पहले सब गड़बड़ सड़बड़ हो गया था. Then rightly she pointed out, these are the ischial spine. Because the tutorial is on anatomical model on like anatomy in relation to surgery. So anything else you want us to explain? And what discussion went, the discussion was very good that
multi-parous prolapse, in which we do sacrohysteropaxy. So for sacrohysteropaxy, you can use those, what do we call, जरा उसको जो वो करते हैं, वो तो नहीं available है, तो you can use this bond and you can tie, you can stitch those mesh through these suture actually. Excellent. Anything else you want? No, we have done surgical anatomy में कुछ और? No, we have done very well. Excellent.
Thank you, Seema ma'am.
Do all the prolapse cases need to be operated? This is a very big question. Do all the prolapse need to be operated? Big no. Do all the rectocele, even if big, they need to be operated? All the cystocele need to be operated? Symptomatic. But if they are causing, maybe she is not relating to it, but you see that all the time she is coming with urinary tract infection, or you've done an ultrasound for some reason and you find that there are back pressure changes which she doesn't know. Try to find other causes also. ये नहीं है कि कोई भी चीज को खट से ये prolapse है, नहीं. There can be other reason also for back pressure changes or hydronephrosis. Investigate it first before you take a decision for advising her for surgery.
Thank you, Seema ma'am. I now take this opportunity to thank Dr. Afshan ma'am, Professor Seema ma'am, and Professor Nasreen Noor ma'am for sharing their valuable insights with us. And I hope this helped us better our understanding of the subject. Thank you everyone who found time for this course. And we will now meet tomorrow, same place, same time. Thank you.